Upon completion of this video, you should be able to evaluate hepatic vein images and spectral waveforms to evaluate for hepatic vein compression or obstructive pathologies in the hepatic venous system. So we have obstruction or compression of flow, as we talked about earlier, caused by any sort of liver disease, cirrhosis from any cause. Remember, cirrhosis can be from alcohol, it can be from virus, hepatitis, and as that gets more, progresses to more severity, it can be cirrhosis. So any sort of liver disease that can cause compression of flow. We talked about hepatic vein thrombus, and people that are at higher risk for that, right? People maybe with pregnancy, or if they've had bone marrow transplant. We talked about how they don't naturally have the anticoagulation proteins that we'd see in normal people, or we have oral contraceptives. So anything to put patients at higher risk for venous thrombosis can occur in our hepatic veins as well, right? Then we have Budd-Chiari syndrome, and originally, traditionally, historically, it was a term used specifically for hepatic vein thrombosis. But that definition has been expanded, and the correct definition, when you hear Budd-Chiari syndrome, that's just obstruction of the hepatic venous outflow tract at any level from the small to the large hepatic veins to the junction of the IVC and the right atrium. And these patients are going to have clinical features that are very unique that go along with this. So remember, this obstruction may occur due to vessel thrombosis, tumor infiltration, or any sort of congenital web, and the IVC may be involved. And these patients are always going to usually present with acute onset ascites, remember fluid, right upper quadrant pain, and hepatomegaly, abnormally large liver. We're going to see very small hepatic veins on 2D, very tiny because they're compressed, right? That makes a lot of sense to you. So we're going to see a non-phasic portalized hepatic vein waveform. Remember, our normal portal vein is monophasic, so we call it a portalized waveform or portalized hepatic vein, and this is just to describe a monophasic waveform. Again, this is from your optional reading. Please check the notes section. I left that in there for you to also look at in the slides. We're going to go over 4 cases, common causes of monophasic or blunted waveforms. And first, it's going to be cirrhosis. And remember, in Western countries, portal hypertension most commonly occurs secondary to underlying liver cirrhosis. And that's either viral, as I previously said, or alcohol-induced. So our number one thing in Western countries, which is extremely common medical problem, is cirrhosis. So that's just a very late stage scarring or fibrosis of the liver, and that can be caused by all sorts of diseases I just mentioned. Each time your liver is injured, it's an amazing organ because it can keep repairing, right, and generating itself. But every time that happens and it tries to repair itself, that process, unfortunately, it causes the scar tissue to form, and this happens repeatedly over and over and over again. For an example, if you're punishing your liver with too much alcohol and alcoholism, eventually, as that continues to get worse and the scarring over and over and over again, it becomes fibrotic and can't function anymore. As you can see this image here, there's a lot of fluid. So all this anechoic area here on the ultrasound, that's massive ascites here. So we have all that fluid there, and you can see this smaller liver here that they're sampling here to find that very compressed and tiny hepatic veins that you can probably barely even see yourselves, right? So it's compressed here, and look what happens to our waveforms. Monophasic, very typical that we'd expect to see in this. So this is cirrhosis. And this makes sense to you guys, right? Because if we have any sort of compression of veins elsewhere, when we talked about it, what do we get? We get a continuous waveform. So we lost our pulsatility, and this is the typical waveform we'd expect to see. Completely different looking than right-sided heart failure, which is very overly pulsatile, or some of the reversal of the S wave, which we see in tricuspid valve regurgitation. And remember, it's important to remember, TR and heart failure can happen at the same time as well. But you know the difference between if it's just right-sided heart failure with the overly pulsatile waves versus we start having that decrease and then finally reversal of S wave when we have TR. So we can also have fatty infiltration. So
That's just going to be a condition where we have a lot of excess fat that's going to build up in our liver, fatty liver. It's really hard to see through that. It's very echogenic. And there's two main types of that. There's the non-alcoholic fatty liver disease and alcoholic liver disease. So NAFLD, which just stands for non-alcoholic fatty liver disease, is just made up simply of a very fatty liver, and it's non-alcoholic related to there. And then our risk factors for our non-alcoholic related liver disease, those are going to be those typical conditions that we'd see in these patients would be diabetes, obesity, as patients get a lot older. Look at this waveform here. This is going to cause compression, right? All this infiltration of this fatty, they're compressing the veins again. We're going to lose our ASV waveform morphology that we're used to seeing, ASVD, and we're just going to have a monophasic waveform here. So again, compression. This unique situation is caused by fatty infiltration. Here's just an example of another monophasic waveform or blunted waveform, and this is caused by a patient holding in complete expiration. So we talked about that. We want to try to have them a tracing of this if we can within just kind of very shallow or gentle breathing. But we do have them take a little breath in, small breath in. We don't want to make sure it's during when they're completely exhaling there. As you can see, it can blunt our waveforms. So ideally, very shallow, normal, quiet respiration will give us our normal looking waveforms that we're trying to obtain. Again, just to review, another example of when we do not want to have our patients Valsalva. So you need to be very careful when you're instructing them to do whole breaths or anything during our liver Dopplers. Again, if you can, try to obtain this waveform if they're having a very shallow or quiet breathing, or have them take a small little breath in and hold it. We don't want them to bear down. As you can see, that would give us an abnormally looking waveform. And we already had an example previously in our previous lecture, or in this article, you'll see it's the same healthy patient, and then they had them breathe with quiet respirations, and we had the complete return back to normalcy triphasic hepatic vein waveform. So do not have them Valsalva. So here's a case report. Remember, Budd-Chiari can be caused by any sort of venous outflow obstruction at the level of the hepatic venules, the large hepatic veins, or IVC. Budd-Chiari is generally classified primarily when this venous outflow obstruction is due to an intrinsic venous problem. So when you think about that, I previously said, think about thrombus, stenosis, tumor infiltration, or any sort of webs, congenital webs there. And secondary, it is related to some sort of extrinsic compression. So if it's left untreated here, we're going to have that increased hepatic sinusoidal pressure and portal hypertension, which we will talk about in the next lecture. And in this case study here, you'll see we have hypertrophy of the caudate lobe, which is extremely common in Budd-Chiari syndrome in this patient. So it might be harder to see, but let me see here if I can. Look at this large caudate lobe here in this patient. So that is a typical view there. We have these serpiginous looking structures, right? And what those are, when you start seeing those kind of develop in the liver, all those are just our collateral channels that are developed in the liver that's still trying to get the blood flow to exit, right? So if those hepatic veins are obstructed there, and in this case, our patient went through a TIPS procedure, which is just a stent graft to bypass the portal hepatic venous system there and just take the blood flow out of the liver. We'll cover TIPS in the fall, but it was totally occluded, and this would make sense. And you can kind of see in this Doppler color, Doppler waveform, it kind of confirms our collateral channels there, and we have our little monophasic waveforms. So again, a good example here of compression here, or stenosis, either or. But look at this velocity. So we have a velocity of 180 centimeters per second on this. So you can see the A-lysine, very tight, small hepatic veins there, and our high monophasic, high velocity waveforms suggestive of stenosis and or compression of those hepatic veins. So here's kind of our progression of Budd-Chiari as it gets worse. So we have our A, S, V, D pattern, completely normal. As you can see, it starts becoming portalized here. monophasic, and in its most severe cases, it's just going to look like a continuous monophasic waveform for our progression of our Budd-Chiari syndrome.